Hi, everyone. Welcome back. Today, we're joined again by Dr. Eddie Stenehjem to give our community update about what's been happening with COVID-19 in the last week. Eddie, as always, thank you so much for joining us. We appreciate the time.
Of course.
So as always, I want to talk about case counts first. Today's data was actually released earlier today, so we can talk a little bit about that. Our daily case counts today was 491 with just under a 10% positive rate. We have a total of 39,696 cases in Utah, 300 deaths, and 2,346 hospitalizations. Intermountain's testing average for the last 7 days is also 2,904, which is lower than the last week by about 200 to 300. Eddie, let's talk a little bit about what those mean. Let's break down the trends and see how we're doing as a system and state.
Yeah, I mean, it's really nice to be able to present and be here and offer some good news in the fact that, I think we can definitively say the trend is by all means stabilized. And now in many places, we're seeing a decrease in case counts. We do see that there's differences regionally, but when you look at Utah as a whole, you can't ignore the fact that cases are now going down. They have been for the past, 5 to 7 days, if you look at the trends. And so that's really encouraging. And, I think the testing patterns are staying relatively similar. And so I don't think that this is just a pattern of testing. I think this is reflecting true decrease in community-based spread, which is really encouraging. It means that something's working. And so when you look at where we've seen the biggest impact, we are seeing cases going down throughout Utah, but the biggest impact so far is in Salt Lake County, where we're seeing the biggest kind of bending of the curve, if you will, to reuse that phrase. But we've seen a really significant decline in Salt Lake County and less of declines in other hotspots across Utah. And so I think this is encouraging, but I also want to make sure people keep in mind that the incubation of this virus is 5 to 14 days, typically 7 to 9 days is that average. And so we just had a big holiday last weekend, and if we're going to see increased case counts due to the Pioneer Day holiday, it's really going to be starting Friday, Saturday, Sunday into early next week. That's when we'd likely start to see increases in cases due to Pioneer Day. So we'll just have to wait and see, but cautiously optimistic in terms of just total case counts. When we look at our hospitalizations, that's still pretty flat. Hospitalizations lag even more than our testing does due to the incubation period. So hospitalizations typically occur 5 to 7 days after somebody gets diagnosed. So it's a really common scenario here on rounds to hear somebody was diagnosed 5 days ago and now getting hospitalized. And so we're still seeing hospitalizations from that peak that we had really kind of 7 to 10 days ago. And our hospitalization rates are still, pretty flat. So we still have lots of people in the hospital, lots of people that are really sick in the hospital that we're trying to, obviously provide the best care possible.
I have two quick questions for you. You said that Salt Lake County seems to be trending downwards. Do you feel like that has any correlation in the fact that we do have this mask mandate now in the county? Has it been long enough to actually make the assumption that there's a correlation between the two?
Yeah, absolutely. There's a correlation. Keep in mind, correlation is not causation. So I can't definitively come out here and say, it was absolutely the masks. That being said, nothing else significantly changed during that time period to really, cause this decrease. So do I think it's the mask? Absolutely. I think it's the mask, but it's, I scientifically can't say that it's causal. But yes, absolutely. We see a nice delay after the mask mandate went in, and then we started seeing this curve go down 10 to 14 days after that. That's what would happen when we start masking up. And so I do think that one of the biggest drivers we're seeing in terms of controlling this, especially in Salt Lake County, is the mask mandate. Absolutely.
You also mentioned before we jumped on that our population of people that are being infected has changed a little bit as far as ages go. Will you talk a little bit about where our case counts are at for the generation or age range it's now affecting?
Yeah, it's interesting. So the Utah Department of Health, I point this way because that's where my screen is. The Utah Department of Health has updated their website, and they've included some new features. One of those new features is looking at new cases broken down by age. And so you can actually see the epi curves by age. And what's most striking is that the people between ages 15 and 24 have really this significant increase in case counts. They've just now started to kind of level off, but that's where we're seeing the increase in cases, is in that 15 to 24-year-old age group, which is pretty striking. I think people will recognize that's a very social group. That's a group that, certainly social interactions is very, very important, just like it's for all of us. But we also see them when I'm out around town, whether it be at a soda shop or whatever it might be, we see them around. And so it kind of fits with what we're seeing in the community. And I think it's also probably one of the main reasons why we're not seeing a really huge spike in hospitalizations when we saw that spike about 7 to 10 days ago, is that the 15 to 24-year-olds just, when you look at the epidemiology of it, are less likely to get hospitalized. That said, I know we have plenty of young patients in our hospitals right now that we're taking care of, whether it be in the ICU or on the standard medical floors.
Another quick question too about testing. Someone just asked us or made a comment about the fact that there's been a dip in demand for testing this week. Thus, the daily testing numbers dropped by about 25%. And at the same time, the case counts has also dropped about 23%. Is this giving us some sort of false sense of security or decline if they're both dropping at the same percentage?
Yeah, you have to consider that. And, we're really looking at the percent positive rate as another indicator that is a little less impacted by how many people are getting tested. And so that test positivity rate is still 10%. And so we haven't seen that decline. If we really truly saw a decrease in community prevalence and community transmission, you'd see that testing percent positive start to decline. So that's something we're really kind of curious and watching for. You're right, we have seen a slight decrease in testing. It's not due to lack of test capacity. We still have the capacity to test. It's not due to the fact that we are limiting testing. But it is something we'll have to kind of keep a really close eye on, and how that impacts our total case counts, especially if we're setting specific public health measures to our case counts. We really have to take that into consideration as we move forward.
Something else I wanted to talk about really quickly too was prolonged symptoms and what could be happening to someone who is, quote, recovered, which the state defines as 3 weeks. They have not passed away. They are now in this recovered category. Are people having prolonged symptoms, and is there any long-term risk to having COVID and then recovering from it?
Yeah, it's a really great question. I think you probably bring it up because there's a recent article that the CDC released in MMWR, which is their journal, that looked at the percent of people that still had symptoms at day 14 to 21. And so this study looked at people of all ages after a positive test. They called them between days 14 and 21 and asked if they still had symptoms of COVID-19. And even in particular in the younger age group, that kind of 15 to 25, 15 to 34 age group, over 35% of them still had persistent symptoms. And so it just shows you that what we're going to be seeing is that there will be a cohort of patients that are going to have these prolonged symptoms. And we're learning much more of kind of what this post-COVID-like syndrome looks like, even in people that have mild to moderate disease. So the mild to moderate disease people are the ones that are at home dealing with this fevers, cough, shortness of breath that's lasting 14, 21, and even longer days after that. And we've heard from plenty of people that they say they still have persistent symptoms of loss of taste and smell, persistent fevers for weeks. This is very different than influenza. I mean, influenza, usually you get sick and you get sick fast and then you recover. And so it really is acting differently, and these prolonged symptoms are going to be something we're going to be studying moving forward. When you look at the hospitalized patients, you look at the people in the ICU, the ones that have been on ventilators, their prolonged symptoms are going to be much more severe, particularly in those that have severe lung disease. When we look at the CT scans of these patients that have been on the ventilator for 14, 21 days, some over months, they have really severe lung disease, really severe lung scarring that will likely cause them to have chronic lung problems moving forward. And so it's definitely an active area of really intense evaluation for us right now.
I want to really quickly talk about schools. I know this has been a very hot topic, and the governor just had a press conference, and it looks like he did announce a few things. He announced that schools will allow kids who have had contact with kids with COVID to attend class in a modified quarantine while they're still in class, distance from others, and a mask. How can we assure teachers and parents still stay safe if that's the case? and I'm throwing this one at you because I just learned this as well. So, but you can come back to this one if you'd like.
Loaded question, man. I don't think I could, even attempt to answer that in 5 minutes. Yeah, I did see he released some standards, so we're going to take a really close look at that. School opening is going to be really an interesting time for us. And I think a couple things to think about before we kind of dive into those questions is that we really have to consider school opening in the context of community transmission. And so if we look at some European countries that have opened schools and done so safely, they have done that when their community transmission rates have been very, very low, much lower than ours here in Utah. And so what they've shown us is that, yes, you can open schools safely as long as you have community transmission controlled. Okay, and that's a huge if. And so I think from my perspective, if we can get this community transmission under control, meaning that this epi curve continues to improve, we get case counts down low, ideally, to the point where we were back in April and May when we were talking about 100, 150 cases per day. If we can do that and we have adequate testing, then I do think we could probably think about how do we open schools in a modified manner and do so safely. If we don't do that and we still have sustained community transmission that's at a higher rates, I think opening schools is going to be pretty dangerous. Yes, kids probably get infected less often. There's probably some biologic plausibility to that as well. But we also know that kids transmit infection as well. And so, yes, kids do well with this, but kids can transmit this infection. And I worry about our teachers, our janitorial staff, the parents of children, maybe parents that have immunocompromising conditions, their parents, and what is the role of a child in terms of transmission is something that really we're going to have to learn and think about. Now, the idea of, if somebody was exposed, can they still be in class? I think that's something that we're really going to have to talk through with the individual districts. And do they have the capability to cohort like that and quarantine effectively to make sure that that person can get back in class? And you also have to think about, well, what about the child who lives in a home of an infected person? So what if mom or dad has come down with symptoms and is getting tested for COVID? Does that child go back to school, or does that child stay home and quarantine until we get an answer for that? Those are questions that I'm hoping are addressed in that document that Governor Herbert document that released today.
There's been a lot of questions too around that entire aspect of what happens if we open schools and then in 2 to 3 weeks we close school again. Is there a cause or benefit to the delay that Salt Lake County announced of going back after Labor Day? Is that because we're trying to get the case counts lower? And will that actually make a difference? These are all what if questions that we don't know the answers to, but I think in the next couple of weeks, hopefully we can see the case counts decline and go in that direction as well.
There's, no doubt that there's a huge benefit to opening schools. It's better for the child, it's better for the adults, it's better for the economy, it's better all around. And that's clearly where we want to go. And I think us as a community needs to realize that we need to get this ready by September 1 or after Labor Day. And really our effort in the next 4 weeks should be a singular focus on driving our case counts get down in the community for the sole purpose to be able to open schools safely. And then I do think that, schools are going to have to be nimble and they're going to have to be data driven. And so could there be a possibility that we're going to have to close and go to remote learning? Yeah, absolutely. Especially as influenza season starts coming in December and January. I think it's just the school district has to be nimble for this and has to be able to follow the data and do what's best for the safety of the child and their families.
I know a lot of school districts too are using or allowing people to use face shields instead of masks as an alternative if for some reason they cannot wear one. Can you talk a little bit about the effectiveness of a face shield versus a cloth mask as far as we know, and if there's a benefit to wearing one versus the other?
Yeah, I would say that the bulk of the evidence is with face masks. And BYU put out a really great synthesis of all this data. They went back and reviewed all the data that we have on face masks and really came out and had a definitive statement that, yes, face masks are efficacious. They reduce the transmission risk. and they improve the safety of the wearer. So I think the vast majority of our data is clearly with the face mask. Face shields, on the other hand, without a face mask is a completely different story. And we definitely don't have the data that we do have with the face mask. It's something to really consider. I mean, there's benefits to the shield, right? You can see facial expressions, which is incredibly important in children. And you can be expressive and people can get those, nonverbal cues. That said, you don't have a barrier in terms of airflow. If that person wearing is infected and coughs, yeah, it's probably going to stop some of that viral transmission. But at the same time, you've got a lot of empty space below it. And so I'd say, based on the science, the face masks are definitely, decrease viral transmission and probably improve the safety of the wearer. We just don't have that data with face shields.
What about plexiglass in between teachers and students? Is it the same thing that we don't have enough data to really support that yet? I know some school districts have talked about having plexiglass in front of the teacher and they're not wearing a mask, but when they go around to go interact with the kids, they put their mask on. Is there a pro or con to removing and taking off your mask so many times as well?
Right. I mean, I think these are incredible, great, innovations that school teachers are coming up with. I think this is awesome. This is what we need to be thinking about. I worry about operationally, how do you do that? And yeah, I think if you were separated by plexiglass and by 6 feet, you are now physically distanced and you've got a barrier. And then if you put a mask on, if you had to go interact, I think that could potentially, keep people safe. We just don't know. Okay. And then you also think about what is the compliance and how often is the teacher behind that? How often are they going out? Are they messing with their mask much more now? Let's put it on and put it off. And so those are the things that, we'll just have to look at and see kind of what transmission rates do for people that use that kind of technology. I think if you were to go strictly based on science, you'd use a face mask.
Another question about face masks for you. Do we have any data to support that if you have asthma, wearing a mask impacts that at all?
Yeah, so, keep in mind when people with severe lung disease come into our hospitals for a clinic visit or whatever it might be, the first thing we do, especially during cough and cold flu season, is we hand them a mask. We hand them a mask to protect themselves because they're the most vulnerable in terms of a patient population. And so I would say that unless you had the most severe lung disease, wearing a mask is absolutely safe. Okay. And we actually promote that in our clinics and in people that come to seek care because we want to keep them safe. We want to make sure that they don't get seasonal respiratory viruses. So unless you have, really severe lung disease, wearing a mask is safe.
And I know there's a couple of different types of masks as well. There are masks that have the valve on them. Some N95s have them. A lot of construction masks have them. Is there a con to wearing these types of masks? I know Intermountain does not suggest that you wear those, but will you explain the why behind the valve not being great for you?
Yeah, I mean, the valve is great for the wearer, for the person who's wearing the mask. I mean, so what the valve does is it makes it easier to exhale. So it takes all that breath that you are exhaling out and shoots it out a one-way valve. Okay, and so it's much easier to exhale. If anybody's worn an N95 mask, they know that when they exhale, they kind of feel this pressure on the mask. And what that valve does is it allows it to release without any kind of back pressure. But keep in mind, you're now essentially releasing your breath just into the atmosphere, which is the whole point of wearing a mask, is to prevent that. And so the construction masks that you see that have that side valve are to make sure that people are protected from the chemicals and the talc and the silica that's in the environment. It's to really protect the wearer. It has nothing to do with preventing exhalation of infected respiratory droplets. And so having a mask with a valve, great for the person wearing a mask because they're probably protected from somebody who's infected, but it doesn't help in terms of reducing the transmission of virus from that person to the community, which is the whole point of wearing the mask. And so we really want people to not wear those valve masks because it takes away the whole benefit of decreasing that transmission.
Another question that just came in, apparently today there was an event in St. George with about 3,000 people in close quarters. About 1 in 10 people, as an estimation, were wearing masks. Lots of people were hugging. There was close contact. This event was outdoors, but could something like this potentially become a spreader event?
Yeah, I mean, this is just so disappointing. I mean, we're seeing rapid increases in cases throughout the state, including in St. George. This is, in my opinion, it's irresponsible. Yeah, being outside decreases transmission. Absolutely, it does. I think we can see that from the protests that happened. We didn't see a huge influx of COVID-19 cases into our hospitals. That said, we've seen plenty of case reports of significant spread at outdoor family reunions and family gatherings and at meals. And so, yeah, it's real concerning if we are having large gatherings of 3,000 people with 1 in 10 wearing masks. That's really frightening, especially considering that the St. George Hospital, St. George Regional Hospital, was almost at max capacity just 2 weeks ago. And so, we don't have a whole lot of wiggle room there to really, offer increased ICU placement. Those people are going to have to come up to here to take care of them if we get full there.
Two more questions along that line too. I know you mentioned this earlier, but I just want to talk about it again really quickly. The state case counts are going down. Are we seeing a decline in our hospitalizations yet? And also, in terms of volume of hospitalized COVID-19 patients, what's the impact on our medical resources and personnel as well?
Yeah, so there was just an article in the Salt Lake Trib, just a couple of days ago showing that COVID-19 hospitalizations continue to rise. And so I can say within the Intermountain system, we've been stable. We haven't seen a decrease. And so we really haven't seen the decrease in case counts has not led yet to a decrease in hospitalizations. And so we are still able to, care for all the patients that come in with COVID-19 and our dedicated COVID-19 units. We haven't had to go to our first phase of surge capacity. That's still obviously available to us if and when we need to do that. But we have not seen hospitalizations or ICU numbers really change at all. We hope that, as case counts decline, we'll see a decline coming in 7 to 14 days after that, initial case count decline. You ask about what's the impact on our caregivers. It's, I was just on the floor an hour ago up in our respiratory ICU COVID unit. We were talking just about that, and they're tired. They're burnt out. They're exhausted. And it's really hard to see some of these patients. And we're now seeing more young patients that are coming in. We're seeing plenty of people that don't have underlying comorbid conditions that are on a ventilator. This is really tiring and wearing on all of the nurses, the caregivers, the respiratory techs, the physicians. And I think one of the things that I struggle with is that we're just starting. I'm hoping we're going to have a lull as we get community transmission under control, but I worry about, what's going to happen in the winter. What's going to happen when people are more forced indoors? What's going to happen when we layer on top of COVID-19 influenza? And so I think there's a continued sense of stress and fatigue in our caregiver. I know, speaking personally, we're exhausted. We work all the time. And this is not easy work. We're wearing PAPRs, which are these big hood-like things, or N95 face masks. And people are nervous about going home to their little ones. And we all take precautions to make sure we don't, bring home COVID-19, but I tell you, it's on all of our minds. It's something we think about constantly and dream about, and it's exhausting.
Yeah, I think it's an interesting perspective, especially because you are directly involved with these people, that people hear this from you. This is not a second or third hand account of someone's thought process on what's going on with COVID. You actually are dealing with it. And I'm hoping that this resonates with people that are watching. I want to talk about patient care too. This kind of loops into what you just talked about with caregivers. There's been some reports that Intermountain's hospitalization lengths have started to slightly decline as far as timeline goes. What is Intermountain doing to help our patients in the hospital, and how are we seeing the slight decline, and what's actually causing that to happen?
Yeah, I think there's a lot of things in this, and I'm not going to be able to point to one particular thing that's saying this is what's causing our hospitalization length of stay decline, whether it be the patients that are on the inpatient unit, on the ward unit, or in the ICU. But I can certainly kind of hypothesize what it might be. And so, Intermountain's a learning healthcare system. And so when we started seeing cases in March, we've set up programs to be able to study our care of patients, and have developed a therapeutic committee that is solely focused on identifying best care for patients with COVID-19. That's led by two just brilliant researchers here, and that's their job, is to make sure that we have the most up-to-date therapeutics available for our patients. And so when you look at how we treated patients back in March and April, it is dramatically different than how we treat patients now. And so now when you have somebody with severe disease, we have a drug called remdesivir, which is an antiviral agent that we've gotten from the state and now are able to purchase from Gilead. We have a convalescent plasma that is from the Red Cross that we get. This is essentially antibodies from people that are recovered from COVID-19. And we have steroids, which have been proven to benefit people in the recovery trial in the UK. And so we have 3 agents now, remdesivir, convalescent plasma, and steroids, that we give to patients that have severe COVID-19. And we have very complex algorithms to go through to identify who would benefit from what therapies. And if you compare us to April, we didn't have any of that. Okay, so for one is that we've gotten better in terms of the therapeutics. And we have developed a system across Intermountain to ensure that those therapeutics are available to any patient that needs them across the Intermountain system. And so whether you show up in our hospitals in Delta or Fillmore or down in Ridgefield, we have a system in place that we can do that. And we also have coordinated infectious disease multidisciplinary rounds that covers all of our patients across the system. And so today from 11 to 12:30, we ran rounds for all of the small community hospitals. Each attending would call in, present their COVID-19 patients. It's run through our treatment algorithm and looking for people that could potentially be on study protocols to make sure that they're on the best agents. Okay, and so we do that for all of our facilities across the system to ensure that we're treating these people up to date. In addition, we've got ICU service lines and medical surgical service lines that when we make a change in our treatment protocols, that gets sent out to all of our facilities across the Intermountain system. And so we can be adaptable and we can change as we learn from our data and from the international data of what's working. And then, I think we also have to think about, what's happened to the demographics of the patients. And so when we look at inpatients' average age, it's declined over the past, 2 months. And so we're getting a younger population, which generally gets less sick, which generally has a decreased length of stay. So I think there's a bunch of confounding, variables in there, but I think one is we're learning, we can disseminate our knowledge throughout the entire system, and the demographics of patients are changing. So I think it's all of those things kind of wrapped up together in terms of decreasing the length of stay. And I think when you look at mortality rates, we've got excellent mortality rates compared to other national centers.
Along that same lines too, will you just give a quick update on vaccinations, if we've had any sort of change from the last week? I know you've mentioned in the past that the vaccination that's happening would not be officially released for about 6 months after they collect data and find out if it's safe or not. But do we know anything further? Has any of that testing begun?
Yeah, I mean, this is such a rapidly evolving field. So Moderna, which is the big drug company out east in combination with the NIH and the NIAID, launched their study, their phase 3 study in the US. First patient was enrolled in Savannah, Georgia, just this last week. Pfizer started their phase 3 trial as well. And then we know the Oxford vaccine, the University of Oxford and AstraZeneca collaboration has started their phase 3 trials as well in Brazil, South Africa, and the UK. And so really exciting times. We now have the initiation of phase 3 trials. Those phase 3 trials have to enroll 30,000 people based on FDA standards and are going to have at least 6 months worth of safety data. And so it's really good news that they started. And now it's just enrolling patients and see how they do in terms of the effectiveness of the virus. We're going to see a second wave of phase 3 trials probably come in this fall. And so the companies like J&J, Inovio, Merck, they are all kind of getting through phase 1, phase 2 trials. And as long as those look good, they'll probably starting phase 3 trials, I would imagine, in September, October. And then those are going to run for 6 months. And so I think you're going to see a constant evolution of the vaccine kind of infrastructure. We'll hopefully start, seeing kind of efficacy results this fall and this winter. And so it's really an exciting time, and not all these vaccines are going to work. Like, they're by no means are they all going to work. But we hope that of these kind of 10 or 11 front runners, that we're going to have at least a couple to choose from. So then manufacturing lines can be running in parallel, and we're not going to be dependent on one company for vaccine. Hopefully we'll be dependent on multiple companies that can really increase the manufacturing and then start disseminating vaccines. Hopefully, if everything goes perfectly and we kind of nail this on the first try, maybe vaccine second quarter of 2021. And so it's going to evolve, and we're going to see more of these trials kind of being started up. And we're looking to say, how do we attract some of these trials to Utah? Ideally, Utah wouldn't be an attractive vaccine trial site, right? Ideally, we decrease our community transmission to be so low that they wouldn't want to come here, because they wouldn't be able to show the effectiveness of the vaccine because nobody's getting an infection. That's what we hope for. But we'll see if we can attract one of these phase 3 trials.
There's been a lot of questions that have come in around school. I just want to give everyone a quick update. We are doing another Facebook Live August 12th with Dr. Hirsch and Dr. Thorell, who we interviewed last week, to speak about schools, children, and COVID-19. So I'm going to hold those questions for their specific Facebook Live just so they can answer those. But any last questions or thoughts that you have that you'd like to say today, Eddie?
No, I think it's, for the most part, we're heading in the right direction. But, for the patients that are up in our intensive care units or in our floors, this is a really bad disease. We've got a couple of very young patients in our ICUs that are struggling to survive. We had 2 deaths yesterday, a patient that had been here for over 2 months, unfortunately, passed away. Another gentleman had been here for 4 weeks and unfortunately passed away. And, our hearts, just go out for their families that couldn't be there. They couldn't be there when they passed away, and they were on Skype or on FaceTime, and it's not the same. And also, when I was upstairs, the impact that losing these patients have on our caregivers is, it can't be understated. It's significant, it's tragic, it's really sad. And so just keep that in mind as you're in your communities, that, we're doing this for the people that'll get sick and get in the ICUs. And we're also doing this for our caregivers that are doing everything they possibly can to take care of these patients. And in my mind, it's the nurses, it's the intensive care unit doctors, it's the hospitalists that are day in, day out, going in, talking to these people, caring for these people, being compassionate, calling their families, FaceTiming with their families, things that they don't usually do, just to make sure that people feel connected. And so, just keep us in mind as we try to decrease the community transmission, and with the focus of, let's get our kids back to school. That's gotta be one of our main drivers as well. So that's it.
Thank you, Eddie. I think that's a really great note to end on. And a couple of resources just for people watching really quick. We still have our COVID-19 hotline available that you can call to get screened for COVID-19. That phone number is 844-442-5224. We also still have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. Thanks so much again, Eddie, and we will chat with you next time.
Thanks, Amanda.